someone wants to make a comment. I just want to ask the mitral panel, expert panel here, starting with what Dr. Cox said, does paroxysmal AFib always degenerate to non-paroxysmal AFib over time if a patient's got moderate MR, and if a patient's got moderate MR and develops paroxysmal atrial fibrillation in and of itself without symptoms of MR, is that an indication to do a repair and an ablation?
The answer to the first part of the question is not always, but usually. So it does, basically everybody who has persistent AFib has gone through a period of paroxysmal AFib. And in the general distribution of the population, it's about 50-50. It's maybe 60-40 in favor of paroxysmal. It may actually be a little better than 60-40 now. That means, because we see it a lot more. So figure 70%, 60%, 60-70% of the people have paroxysmal, 30-40% of the people have non-paroxysmal, and almost all of the latter have gone through the former. Whether or not that could be used, I don't know the answer to that, Mark. I think it's a little iffy to use that by itself as an indication for surgery. Are you talking about indication for mitral surgery?
Well, then you'd do both, yeah.
So you'd operate on mitral valve earlier if they have AF rather than if they don't have AF. Yeah, that's
if they don't necessarily have an indication, you know, a classic indication for mitral valve repair, like moderate. What do you think? Would a moderate MR and paroxysmal AFib be an indication for surgery?
AFib is AFib was, as Carpenter said, a turning point. That's one of the signs that it's time. It's a turning point. Yeah. Atrial fibrillation is a turning point, and yeah, there are patients that have moderate mitral valve regurgitation that don't feel well or develop atrial fibrillation. And if you're young and you're having AFib with moderate, I highly recommend you get a stress study and prove that it's severe. Wouldn't even bother. I would just go ahead and do that patient. You know, the asymptomatic one where you don't have flail segment and your ventricle small, that's when you better really document severity of MR. But a patient that has AFib with moderate MR that is otherwise a low-risk patient, I think they all get surgery.
Yeah, I think one of the things you have to worry about in that situation is an atrial cardiomyopathy. You know, that's the problem.
As the cause. We've got time for two questions. Oh.
Pedro, I just want to say Tirone was right. I think I counted 40 people taking photos or videos of your talk. Number one, it shows you the importance of myocardial protection, but two, I think that where Mark and I were just talking, we need to add this discussion. You can still talk about pediatric mitral valve disease, which I like more, but I think we got to add this discussion more because this was really interesting. And I will take the honor of the floor for 1 minute to ask you one quick question. Because I've always used blood cardio because I want to keep the heart cold. So I give it every 30, 35 minutes. You're saying with Nido, with this solution, we could give it every 40 minutes and not get in trouble. We can be a chicken. I always say I'm a chicken heart surgeon.
Yeah, I think that's true. I think the exceptions are if the heart starts beating again, you know, you have a lot of collateral flow. You need to stop that heart. Yeah. Resting is very important. So if it starts to beat, you got to give another dose.
Yeah, just from what's the second dose? Your own strategy, not what other people do. What would you recommend for the second dose?
For my strategy, if I think I'm going to be done in about 20 minutes, I won't give another dose. Okay, but if I think it's going to take me another half hour and I'm cross-clamped more than an hour, I give another dose. And the other exception would be if I'm dealing with somebody who's really in bad ventricular dysfunction or severe hypertrophy, I think you have to religiously give it every 45 to 60 minutes. Half the dose, yes.
Pedro, I really enjoyed your talk. It was fascinating. It occurred to me, the only reason you give this second dose is to cool the heart down, right?
Not really. Not really. It's got a ton of buffer. And so what I'm trying to do is change the pH. And in fact, we measured that. This is in animals. We didn't measure it in humans, but you can maintain the pH a little bit less acidotic by giving that additional dose. You don't need very much because it's the buffering agent that's doing the trick.
So topical hypothermia, what would that do to your first dose in terms of how long you could wait?
if you keep the heart cool, I mean, I have seen situations where they've given one dose for a 3-hour cross clamp time.
3 hours?
Yep.
Did
I've
they
seen
use
that.
topical hypothermia?
Yep, with just hypothermia. Now, the way we use hypothermia is we use total body hypothermia. So we're running 28 degrees. The whole
okay.
body's
Yeah,
at 28
yeah.
degrees. I don't think you ever do that in the adults, or very rarely. If you're doing an arch, maybe. But so the entire area is cold. If you're using topical or some sort of protection, an insulator even, that's all you need to do. And just keep that heart, you know, if you touch it with the back of your hand and it feels cool, you're fine.
Yeah.
And the other thing that I always do, if I touch it and it feels soft, like you have a fillet that's really soft and tender, you're fine. If it's been feeling like it's been sitting in the refrigerator for about 3 weeks and getting a little stiff, you're in trouble. You're in big trouble, okay? And you better do something quickly to try to help. And so it's very simple things like that that really make a difference.
3 hours.
Yeah, that's a topic that affects every single cardiac surgery, right? We saved your congenital mitral for the Norwood postgraduate course. That'd be good.
Thank you.
Okay.
Masashi.
Okay. I have a
Quick
question for Annie. Congratulations on your great repair. But that surgery can be done under beating condition, including the mitral annuloplasty. Or if there's any problem, that annuloplasty can be done with a short cross clamp. That makes the postoperative course much easier.
I mean, you can do it, but you had this big mass of thrombus the size of my head in the patient's heart. So to remove all that and remove all the bits with the heart not arrested, it can be done. But the question is, why
Or,
do we need to do that?
If any concern, short cross clamp and remove the thrombi, and after that, things can be done under beating condition.
Yeah.
The repair itself is
anything can
done.
be done,
Yeah.
but.
Thanks, Masashi.
I'm intrigued with the rhythmogenic mitral prolapse. I'm going to ask David Adams 2 questions, quick questions. One, if a person has a significant burden, and who knows what percentage that is, but if they have a significant burden of mitral of arrhythmia, would you intervene in that person's mitral valve prolapse with regurgitation sooner than you would normally? That's my first question.
Yeah, we would do, again, these days, we would enroll the patient and get a PET MRI. I think that if the PET were completely clean and had moderate MR, patient passes an exercise study, we'll put it in the middle arm, we'll follow it. But certainly our antenna are up for patients that are having arrhythmias, because again, remember, we're trying to study it. On the other hand, you know, the way that grant happened was that a congressman's wife, who was, I think, 46, was on a Zoom call and keeled over and died, and she was being followed for moderate MR with palpitations and had a Holter that had, you know, moderate burden of PVC. So it's not that it's not a benign disease, and I think that we're still learning, but I think we would certainly have a much lower trigger to intervene.
So you're saying you put them in a study?
We put them in a study, but I'm saying we would have a much lower,
Yeah.
we would definitely exercise them and with a Holter in place, so we would know what's going on when they're active.
My follow-up question to that is that you showed a very interesting picture with the spinnaker versus a regular sail and reducing the stress on the mitral valve and posterior annulus. Are we going about this wrong? Should we give them a mitral valve replacement? Take all the stress away from the cords? Most of the stress away from the cords?
You know, I think that gets back to normal function. Normal, you know, anatomy determines function. I think one thing I will say, we were talking about resuspension of big leaflets and having big floppy valves, and let's oversize rings and do American corrections and all that stuff. I think, again, you know, nature usually doesn't make mistakes. We have a short posterior leaflet, a longer anterior leaflet. We co-out posteriorly. It's very deep. It takes tension off the cords. That's why they don't re-rupture, even though we don't change genetics, and it probably improves ventricular function. So I think whatever valve repair you want, I think trying to get back to the closest to normal anatomy is the best way to try and do that. And so far, we've seen the arrhythmias get better. We'll learn through this study whether the inflammation resolves.
Do you have an arm of a replacement to see whether or not it is it different?
Yeah, I'm afraid I don't have equipoise to do that one, not based on what we've seen so far. That would have been a better question 4 years ago, but now we're seeing most of these patients, we're seeing a marked decrease in their burden with repair.
I think we're going to have to end this session.